everyone, and welcome to our CDPH and CMA Virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session, which is on provider consultation programs for supporting youth and maternal mental health. In this time of vastly increased need for mental health care, all types of physicians and other healthcare providers can benefit from the assistance around mental health care needs of patients that they see. We all need to skill up, and we're so lucky to have Drs. Steinbushel and Dossett here, who will share what CalMAP and LA Promise programs are and how they can provide clinicians with real-time consultation with behavioral health physicians so they can help ensure patients receive timely access to mental health care. But first, we'll hear from Dr. Erica Pon, whom we so appreciate for continuing to make time for us in her role as Director and State Public Health Officer for the California Department of Public Health to share an update. So let's start with disclosures. These are the disclosures today. Next slide, please. And our agenda. Next slide, please. Just a reminder that this series is accredited for CME credit, so you'll get that survey after the completion of the webinar. You can attest to your attendance, and then we'll send you out your certificates. Next slide, please. Okay, with that, we'll start with Dr. Pon. Thanks for being here.
Great, thank you so much for having me again. And I'll just launch right in to try to give a few updates. Next slide. On where we are in thinking about respiratory, next slide, respiratory virus season and planning ahead for 2026, and of course, a very active area around our respiratory virus season vaccine recommendations. And I know you have a really packed agenda, so I'll try to go through verbally a lot of this quickly, but you'll have the slides for more of those details. Next slide. So what are we thinking and what are we seeing as far as trends with respiratory viruses right now? Next slide. So I think it's helpful to sort of show for the last year's season, because I think as people learn and think about changing vaccine recommendations or where we're seeing the highest risk, this slide, and I apologize, the 1 to 4-year-olds are really hard to see, but one thing to really just note here is that the less than 1-year-olds hospitalization rates are actually similar to the over 65-year-olds. So those infants are actually, and we see this with flu too and other diseases that potentially have kind of a U-shaped curve of high risk at lower and are young and are old. So again, the hospitalization rates for infants are similar to the over 65. And then I'll talk in a little bit later about the latest American Academy of Pediatric recommendations for COVID vaccinations. But these are kind of the trends. We are seeing some uptick. I think we haven't put on the slide the as of date on here, but you can see again that we're seeing an uptick here in late August. Actually, this is weekend date, late August, of hospitalizations starting to increase. Next slides. And this is national data here. Okay, next slide. So what are we seeing here in, oops, sorry, go back again briefly. So as far as test positivity, we are definitely seeing a much higher test positivity. Of course, a much lower testing volume, but we're seeing like a moderate level of test positivity now at about 12.8%. And you can see here, this is similar to last year around the same time, a little teeny bit higher than the, actually, sorry, this is a little bit higher than the 24-25 season and similar to the 23-24 season. There are, of course, as always, regional differences throughout the state, and Northern California is experiencing some higher test positivity. And then our wastewater data is showing a 40% lower than our peak activity during the last year's summer wave. Deaths, thankfully, are currently lower than the last 2 seasons as well as far as those summer waves. And then hospital admission rate, this is our you can see here the green line of the COVID admissions are at about 3.9 per 100,000. And, one of the thresholds that shows sort of a next higher level is when it gets to above 5, but you can see again that so far the hospital admission rate is looking lower than the last 2 seasons for this time of year, or these sort of late summer surges that we've seen. And as I was emphasizing in the previous slide, older adults and young children do have the highest rates for respiratory viral infections, including COVID-19. Next slide. So just briefly too, this is really looking at what are we projecting for this season. I know this is a question a lot of you have as clinicians, and so we do think that the COVID activity will potentially decline by October before the winter peak of other things, and that might be right when flu and RSV are increasing in activity. And right now, the combined respiratory activity is expected to peak probably end of December, early January, which has been pretty similar to previous years. So that's the timeline. And then next slide. Trying to compare again to previous seasons, the projections that we're seeing, the left side is our California projections and the right side is the national projections, and both are projecting that potentially the combined peak hospitalization of all 3 of these viruses will be potentially similar to last year, with projections are that the flu would probably still be the predominant virus, leading to most of that. And you can see here in the California projections of the proportions we're projecting right now to potentially be COVID and RSV. So more to come, but we think it might be similar than last year, and acknowledging that last year was one of the most severe flu seasons we've seen in many years, but still lower combined peak hospitalizations than the prior 2 seasons. Next slide. So we had launched our COVID updated surveillance dashboard, and we'll be adding the other 2 viruses to that very soon. We also have our wastewater surveillance dashboard, and then CalCat is where we do those projections. So those are some snapshots from those that you can refer to throughout the season, and it'll help you just see and track, where are we in the season, how does it compare to other years, and which direction the trends are going. And hospitalization rates, et cetera. So those links will be there in those slides that you'll receive, and how you can continue to track with us and look at what's happening in our state. Next slide. So moving on to vaccine recommendations. This is, of course, an area of a lot of important attention right now, and a lot of confusion. Next slides. I wanted to highlight a couple things that are new related to, so for RSV vaccine, the main change for this season is that instead of recommending RSV vaccine to 60 to 74-year-olds at increased risk, it's actually 50 to 74-year-olds this year at increased risk. And then for all adults over 75 years of age. So that's the main change. This was actually a vote of the Advisory Committee of Immunization Practices that has moved forward, and we endorse this recommendation. And you can see here some of the key risk factors that are listed as what puts you at increased risk for severe RSV disease. Next slide. And then the American Academy of Pediatrics did come out with their 25-26 COVID-19 vaccine recommendations a couple weeks ago. And the American Academy of Pediatrics, I want to also just briefly point out, has been doing immunization schedules and vaccine recommendations for, I think, about 90 years, but a long time, and actually started doing immunization recommendations before the Advisory Committee of Immunization Practices was actually developed, and they're going to continue to do that. And they always use a very trusted evidence base to make these decisions. And so these came out, and we actually had liaisons from our department that were on the Committee of Infectious Diseases call related to this, and they really looked at hospitalization rates of across the spectrum of pediatric ages, and their recommendation has been that children and toddlers 6 to 23 months of age are recommended and are at higher risk for severe disease, and they should get that initial series of COVID-19 vaccine and an additional dose. And then all pediatric ages, if they have any immunocompromise, should get at least 2 doses, depending on history of prior doses. And then it's also, they made clear that for 2 to 18 years of age, if they're at high risk of severe COVID-19, that's one indication. If they live in a long-term care facility or congregate setting, they've never been vaccinated, so they've never had that primary series, or if they have household contacts at high risk for severe COVID-19, or really importantly, if they want to have access and get vaccinated, they should have access, and a parent or guardian should be able to get that protection for their child and get vaccination. So that is the American Academy of Pediatrics recommendations, and that is what the California Department of Public Health endorses, and is different than what we have seen coming out of HHS. Actually, that'll be a good segue to the next slide. And then as many people have likely heard, at the end of August, FDA approved 25-26 COVID-19 vaccines, but they only approved it for people 65 years of age and older, or less than 65 with at least one high-risk condition. And then there were some different minimum ages that have been authorized for the different manufacturers. There is, we think, an ACIP meeting scheduled for September 18th to 19th, and it is, they did not actually have a vote with the Advisory Committee on Immunization Practices at the last meeting, but it's on the agenda for this upcoming one. So we will see what happens related to what that Advisory Committee recommends around COVID-19 vaccines, but we have really been relying on, given the termination of the vaccine experts with that subject matter expertise, we're really relying in California, and I'll talk about the Western States Alliance in a moment, but on other kind of vaccine recommendations from the American Academy of Pediatrics. Just yesterday, the American Academy of Family Practice came out with their respiratory virus vaccine recommendations. So we're looking at that closely. They've just issued those recommendations for adults. And then the American College of Obstetrics and Gynecologists has also endorsed vaccination for pregnant women, and we're endorsing that as well, despite what has been coming out of the federal HHS. The distribution of vaccines, we were starting to see that come into California, and we recognize there's a lot of confusion, a lot of access issues. There are some processes in place, and we'll likely have updates very soon on what we are doing in California to really promote insurance coverage, vaccine access, and scope of practice for pharmacists and others to be able to provide vaccine based on these recommendations from other trusted national professional organizations. Next slide. So as you all likely know, there have been a lot of changes with new membership of the advisory committee, and I already mentioned the next meeting. There's no change currently in vaccines for children or Medi-Cal formulary, especially related to COVID-19 vaccines. So again, as the new 25-26 vaccine comes in, there's no change right now in any of that reimbursement. And then I already highlighted the AAP and ACOG, and again, just yesterday, the AAP released their adult recommendations. So we're taking a look at those now, but in general, they have generally aligned with, other kind of evidence-based recommendations in the past. And then many of you may have seen there's a group called the Center for Infectious Diseases Research and Policy that comes out of the University of Minnesota with a lot of expertise in infectious diseases in general, and they pulled together a group of experts that put together a vaccine integrity project. And they also looked at data for the last I think couple seasons, basically to look at evidence base for the fall and winter immunizations. And they reviewed published data, did a very intensive review. You can see the webinar online and an executive summary on COVID-19, RSV, and flu vaccines. And one of the bottom lines that came out of that is evidence continues to support safety and efficacy of COVID-19 vaccines, including healthy children and pregnant people. And so with all of that in mind, California Department of Health continues to endorse these other national organizations. So AAP, ACOG, and as I mentioned, we'll be looking at the AAFP recommendations very soon. Next slide. So I just wanted to put a quick reminder here too of how low, even before this season, vaccine coverage rates were nationally, and our California rates are very similar, but this is nationally. You can see just very poor uptake of all three of these vaccines, and unfortunately, very concerned it's going to be lower this year with a combination of vaccine confidence and confusion about access as well. So really hope that all of you as frontline providers can continue to promote vaccination for these really important high burden diseases that fill our hospitals. And you all know as you take care of a lot of these ill patients, but really hope we'll have your partnership and continue to endorse the safety and efficacy of these vaccines. Next slide. And then finally, we're really excited to share that we launched a new alliance to uphold science and integrity in public health. This was announced, I guess it's been a couple weeks now, and essentially California, Washington, and Oregon, and now Hawaii actually has joined, are sharing our commitment to continue to have public health recommendations to support safety, efficacy, transparency, access, and trust. So we'll be aligning our immunization recommendations with trusted national medical professional organizations and looking at the evidence base that they are making those recommendations as well. So we're working to align those. And again, more to come very, very soon on what we're doing specifically in California related to insurance coverage and ability for allied health professionals to provide these vaccines as well. So stay tuned on that. We hope that more information will be out very, very soon. And this alliance, I also just want to emphasize, is not going to be like a separate advisory committee on immunization practices. It's really looking at what are the recommendations out there and which ones do we feel comfortable that have the right evidence base and the transparent evidence base to make recommendations for our states and for our insurers and for our communities. Next slide. And just one last quick thing to just kind of share, like the precedent has been that there's a lot of data and evidence compiled from the CDC subject matter experts, and also some of the manufacturers bring their data, especially with new vaccines, to the advisory committee and immunization practices, and then the CDC signs off on those. And that has been a precedent to really inform things as far as insurance coverage with the Affordable Care Act, and a lot of health insurers have relied on that. A lot of state statutes, including California, had relied on those ACIP recommendations, and they often aligned with, the specific medical professional organizations also typically would have their specific vaccine immunization schedules, and they, for the most part, always were aligned with the ACIP, but I think that is now what we're seeing as a divergence. So we are seeing, really data coming out of Vaccine Integrity Project, AAP, and then other recommendations coming out from other organizations. And those currently, as far as what's already been posted, are what we are more confident with and endorsing. Next slide. Just some quick acknowledgements, and then I think that is it for me. Next slide. Thank you so much.
Thanks so much, as always, Erica. It is really great to get that word, and we will look forward to more of that, just previewing that we're going to have, hopefully, Dr. Pan and Dr. Rita Nguyen talk to us in November about both the updates on immunizations and also other public health decision-making impacts that are really being challenged by some of the changes in advisory groups federally. So now I am thrilled to be able to present our next two speakers. We have Dr. Petra Steinbuchel, who is a child and adolescent psychiatrist, a professor of psychiatry, and the director of the California Child and Adolescent Mental Health Access Portal, known as CalMAP. That is a child and youth behavioral health initiative, CalHOPE program, which is powered by UCSF, and it's aimed at increasing timely, culturally responsive, and evidence-based mental health care within lower stigma primary care settings, which I think is super key as a primary care physician myself. She's held key leadership and teaching positions at UCSF and has led efforts to implement expanded access of evidence-based interventions to diverse and vulnerable populations, including developing collaborative partnerships between behavioral health and primary care practitioners in inpatient, outpatient, and school-based settings, and really grateful for that work. And we're thrilled to have Dr. Emily Dossett, who is a reproductive psychiatrist and associate clinical professor in the departments of psychiatry and behavioral sciences and of obstetrics gynecology at USC's Keck School of Medicine, where she's been named Teacher of the Year 8 times. Dr. Dossett serves as the medical director for 2 federally funded perinatal psychiatry access programs. One is called the Promise Program in Los Angeles County and Champs for Moms in Mississippi. She does a lot of consulting with other neighborhood programs in high-risk perinatal women, and also advises organizations such as the LA County Department of Mental Health Services, or of Health Services, State of California's department, and SAMHSA, as well as ACOG and journals. And also is certified as a Menopause Society perimenopause provider. So I'm going to be giving her a call immediately after this presentation. So with that said, I'm going to let them talk, and we really appreciate having you both. Petra, we can't hear you. Maybe we can advance the slides, and our team will work on your sound in the background. I don't know what happened. We were talking before. Sorry for these technical difficulties. I'm wondering if our team in the background might just advance to Dr. Dossett's slides, and we can start there. We had some technical issues with sound before. Dr. Steinbushel, maybe you can restart the whole computer in the background. I don't know if you have any other thoughts, but that's my only thought.
Yeah, I'm happy to do that. I think okay, that's me. All right. Well, we can go back then. Can you guys hear me? Am I good?
Yes, we can hear you.
Great. I got a thumbs up. Okay, I thought I was, but I just given what just happened to a picture. I just wanted to make sure. So sure. So I'm going to go ahead and I'm going to give a little more background than what I'd originally intended, because Petra was going to sort of lay the background, lay the foundation really for what I was going to say. But basically, both the CalMAP program and the Promise program, which are the two that we're going to be talking about today, are called psychiatry access programs or mental health access programs. And the goal of both of these programs is to try to bring expert evidence-based care to frontline providers as they're actually caring for patients with mental health and substance use issues in their own practices. So what that looks like is the heart of it is really a provider to provider consultation line. And for the Promise program, what that means is we have reproductive mental health specialists that are available during business hours, Monday to Friday. And if anyone calls the Promise program, we're able to answer questions around assessment, diagnosis, treatment, medications, etc. And then the provider actually takes that information, takes those recommendations, and really, makes their own decisions about how to apply it to patient care in the medical home. So the idea is that we take the little bit of expertise that's out there, because there aren't too many of us who do reproductive mental health, and try to bring it to patients through their frontline providers in such a way that it's all in the place they're already getting care. It's, like Kim said in her introduction, much less stigmatized, and really the scale is much larger. So that's the goal. I guess I'll just keep going, and Petra, you can kind of jump in here when done. But really the goal of our program, the Promise program, is to increase capacity. So that was my brief off the cuff introduction. So thank you for bearing with me. But I'm going to take a step back now and really talk about what we're even discussing when we talk about perinatal mental health and substance use disorders. And I think the easiest way to do this is to talk about kind of the evolution of the terminology. So when I first started doing this, which was about 20 years ago, whenever you said, yes, I work with people who are pregnant and postpartum and have mental health issues, everyone said, oh, postpartum depression. And I would say, yes, postpartum depression and postpartum anxiety and depression in pregnancy and anxiety in pregnancy, because there was this idea that no one really had mental health issues in pregnancy. It was all postpartum and it was all depression. As time went on, though, it became more and more recognized that it isn't just pregnancy, or it isn't just postpartum, it's also pregnancy, and that it isn't just postpartum per the DSM definition of 4 weeks after labor and delivery, but it's up to a year. So we started using perinatal as the time frame. And we also switched from saying depression to mood and anxiety disorders, because mood includes depression, but also bipolar disorder, which is actually quite prevalent in this population, as well as anxiety disorders. And there's actually more anxiety out there than there is depression. So we moved from postpartum depression to the phrase PMADS, perinatal mood and anxiety disorders. In even more recent years, though, we've broadened that term further to include substance use disorders. Because the reality is there are a lot of people out there who use substances and get pregnant, many of whom are able to stop, but a lot who aren't. And by definition, that's a substance use disorder. And so our program and programs like ours are actually called Perinatal Mental Health and SUD programs, PMH SUD, which is not as easy to say as PMAD. So that's a little bit of a bummer, but it is more all-inclusive. Next slide. PMH SUDs, perinatal mental health and substance use disorders, are the most common complication of childbirth. Yet they are often not acknowledged, much less screened for, or definitely much less treated, right? So if you look at the prevalence, obstetrical complications that tend to get a lot of attention, and understandably so, include preeclampsia at 9% of the population, gestational diabetes around 6 to 7%, and then postpartum hemorrhage at 3%. All of those are important. All of them deserve attention. If you look, though, at perinatal depression, and here I am talking about depression, the rates are much, much higher. So it's up to 40% of Black women, roughly 1 in 3 Latina women, and about 10 to 20% of white women. So there are huge racial and ethnic disparities in that as well. And then perinatal anxiety across the board tends to affect about 1 in 5 postpartum women. Next slide. It's also important to remember that while we have this incredibly high prevalence of PMH SUDs, we don't have enough people who actually can treat it. We don't have enough providers out there for a variety of reasons. And this map is actually of Southern California, where I am. I'm based in Los Angeles, but I have the citations at the end. Hopefully you'll get the slides. And this is put out by a really excellent policy group. And there's a map of the entire state of California. And the lighter the circle, the less the gap, but the darker the circle, the higher the gap. And there are parts of California where really there's no one out there who does this work. And even in LA County, which is a little bit less on the gap side, LA County alone needs 252 additional providers to make up the gap between the need and what we have to potentially address it. Next slide. Next slide. Thank you. So you can go back one. Great, thank you. So Promise is our solution to this. It's our answer to the incredible need, to the lack of providers, and to the inequities that exist around this. And Promise stands for Perinatal Resources for Optimal Mental Health Interventions and Substance Use Treatment Excellence. I cannot take credit for that acronym. It was made up by our executive director. My hat's off to her for that. But it is a provider-to-provider consultation phone line, as I mentioned earlier, and we answer questions in real time. And we give advice and assistance on taking care of pregnant and postpartum patients, really with any aspect of mental health or substance use disorders. So screening, diagnosis, we have a resource and referral database. And the piece that people seem to really be hungry for is actually psychiatric med management. Next slide. And while the provider consultation line is really the heart of what we do, our ultimate goal is actually to increase access to these services by building capacity. So we do provider consultation, but the other two kind of pieces of our three-piece pie are resources and referrals and provider education. Next slide. So over time, this is really data from just the past year or so, we've been able to really facilitate a lot of trainings around perinatal mental health and SUD, around the Promise line itself. We also offer trainings in intimate partner violence because it's such a real issue in this population. And you can see the total number of providers we've been able to train and how that's changed over time, and also the number of consultations. So we're very new. I actually got a email from one of our psych NPs earlier this week, or last week actually, saying it was her 1-year anniversary. So we've really been pushing on marketing and outreach, and the number of consultations we're getting is increasing week by week. So we're very hopeful that this model will actually meet some of that need, some of that gap. And I will hand it over to Petra. So she's going to talk about what this means on the child side.
You so much. I hope everyone can hear me at this point, and really appreciated the quick pivot and teamwork. And I've actually known Emily now for, I think, almost 5 years, and it feels like such a natural fit to have the perinatal consultation and the child and young adult consultation come together, because of course, if you take care of the mother, then you can help to prevent a lot of impact on any children involved, on the whole family. And really, this is, these programs are meant to be kind of preventative / early intervention with accessing the right care at the right time by the right person. So I'm going to share a little bit about CalMAP. Next slide, please. I think these statistics are probably familiar to most folks here, but I think importantly, 1 in 5 kids have had a diagnosable mental health disorder even before COVID, and those rates only went up during the pandemic. One of the few silver linings was that it helped to shed more light onto this. It was no longer kind of an, oh, we don't talk about mental health, that's an over there kind of problem, to really kind of bringing it into focus and into the spotlight that yes, everyone is affected, and it made it more okay to talk about. And this is a really important and maybe not so well known part of this, is that 50% of mental illness starts by age 14, 75% by age 24. However, there's often a really long lag time between the onset of symptoms and the time to diagnosis and treatment. And that lag time can be as long as 10 or 11 years. And that is for a number of reasons, including, stigma and maybe not being able to recognize it easily. But, many more kids go to see primary care providers than they do to go see a mental health specialist. And that's a perfect opportunity to increase the ability to recognize and begin to assess and maybe manage some more mild to moderate conditions. Next slide. So as Dr. Newell Green pointed out, primary care is a much more accessible and much more utilized and lower stigma setting. And I work with pediatricians who have seen families for 2 and sometimes even 3 generations. A lot of people will not take you up on that referral to go see a psychiatrist, certainly, or to see a therapist. And then even if you do try, if you have a family that's willing to take that leap, that it's really hard to get an appointment and the costs are high. The services may not be readily available in the area. And next slide, please. Some of you may be practicing in integrated care settings. Integrated care can mean a lot of things, and there's co-location that often happens within federally qualified health center sites. There is a fully integrated system where you're all on one shared electronic health record and you have a coordinated system of care. We are more in this kind of earlier area of coordinated care that's driven by consultation from a hub site, and that we work directly with PCPs to help meet the patient's care goals. Next slide. I don't know how many folks have heard of the Child Youth Behavioral Health Initiative, but this was a 2021 legislation that funded a number of different innovative approaches and supports for increasing youth mental health care access for youth age 0 to 25. And there are about 20 programs that are funded through this Youth Behavioral Health Initiative, and ranging from anywhere. Live Beyond is around living beyond ACEs, finding meaning and purpose and identity, so that you're not just your ACE score defined by your trauma. Never a Bother is an anti-suicide campaign that offers direct support, which is especially critical right now in light of various funding cuts. And then certified wellness coaches are a new and emerging type of professional resource that's offered through schools where youth can access coaching in real time when they need it. Saluna and Bright Life Kids also offer one-to-one coaching, as well as a number of resources based on age and the family's needs. And then the CalMAP program is in this clinical intervention realm that is kind of on the lower intensity side, because it's delivered through primary care, but it is meant to really increase access to care. And then you have more intensive supports kind of down on the continuum. Next slide. So what are the core features? Similar to the Promise program, we offer that on-demand, real-time consultation via telephone. We also offer e-consults for folks who are familiar with that. E-consults are a way of sending like an email type communication for multiple specialties, usually that are harder to get an appointment with, where you may wait a long time to see a dermatologist or an endocrinologist. We offer that for psychiatry, and those tend to be for people who really have a very specific and focused question, and they can easily ask it via email. The phone consultation is really for people who oftentimes will have folks who are maybe late career who say, I've never prescribed an SSRI before, I feel so uncomfortable with this, and I'm not really sure if I should. Can we talk it through? And so you have this brief conversation that really involves kind of a learning exchange and a deepening of knowledge. And then we also offer continuing education and practice transformation assistance, and then a number of resources and referrals on our website, which I'll share in the chat. Next slide, please. So here are the main mechanisms. PCPs can consult directly with child and adolescent psychiatrists, psychologists with specialized expertise in substance use, autism, and mood and behavior concerns. And we also have a number of care coordinators who are familiar with both the resources that are available in different geographic areas across the state, but also more importantly, how to navigate the system of care. We know it's really confusing to get connected, and so education on how to do that is part of what we can offer. And just want to underscore the point that no call is too small, no question is too small. You know, I think a lot of physicians tend to be kind of perfectionistic and want to, you know, feel like they have to know everything already, but that's exactly the point, is that we're here to help. You don't have to know anything. You can just talk it through with us. Next slide. Here is a sampling of the types of trainings that we offer. So we have a number of live webinars that are hosted up to twice a month, and those offer CME as well as all kinds of CEU for social workers and psychologists. And these are mostly stratified by, you know, specific conditions and topics. We also offer 3 modalities for ECHO virtual learning collaboratives, if folks are familiar with that. That has both a didactic component to it that's usually about 20 minutes, so a really succinct kind of bite-sized you know, topic that you're learning about, and then also a peer case consultation that can be facilitated and added to by the subject matter experts that gave the didactic. We offer that for kind of our core topics, which are ADHD, depression, anxiety, autism, suicidality, and SSRIs. And then we also offer an advanced series because some folks have graduated from the basics and want to tackle other subjects. And then we also offer school-based ECHO consultation for school-based folks. We also have 18 modules of 1 hour each of free CME that are available on demand, including this core certification and these topics for family physicians, and that's AAFP certified. Next slide. These are just a sample of some of the topics that we have coming up. And here's a QR code that you can use to register for these, and we'll share this deck at the end. Next slide. These are our series of live boot camps, which we're affectionately calling Think Like a Shrink. We're learning how to think like a shrink. And we have 3 main modules as part of these, with the first one being kind of the basics again, ADHD, anxiety, and depression. And then we've gotten a lot of input and feedback around, you know, more and more cases of autism that, you know, PCPs are managing within primary care, you know, sometimes together with other behavioral health supports. So kind of unpacking, you know, disruptive behavior from complex ADHD and or autism, or when those 3 things can come together. And then our adolescent risk-taking module focuses on adolescent substance use and also concerns for suicidality and self-harm, and also disordered eating behavior. And for anyone who would still like to register, we're offering something in the Bay Area this coming Saturday. It's actually going to be in San Francisco, and you're still welcome to register for that. And then we have some other events coming up at UC Riverside and Chalk, and happy to share the link to register for those. Next slide. So why is this important? We know that, you know, from meta-analyses looking at similar programs in other states, that progressively over time, these programs increase access to mental health care in a timely way, and it's at no cost to clinicians or families. And, you know, sometimes what we'll do is offer kind of a bridge consultation where someone, you know, clearly does need to be referred to specialty mental health, but that appointment is maybe 3 months out. And so we can help to get things started where, you know, we can help the PCP provide some education, maybe start some diagnostic workup through specific rating scales or lab evaluation, and, you know, and maybe get some treatment started in the meantime. And really this is about trust, which is something that is so key and so core to primary care, and that this is, you know, especially in our current times, people may feel even less comfortable in some ways accessing care through specialty mental health. I also want to underscore that the time you spend consulting may be billable. Next slide, please. So you can register online. You can also register via phone call if you prefer that, and you can start consulting right away. We're available Monday through Friday, 8:30 to 5, and you get a fast free callback from a child psychiatrist within 5 minutes up to 30 minutes. Next slide. This is just a sampling of the types of questions that come up. Anxiety has always been the most common question that we get asked about, and ADHD is usually up there. And then autism has actually replaced depression now for the past year or so. So definitely seeing an increasing number of concerns about autism really across all ages. I think there's increasing recognition about maybe later diagnoses. And it always kind of impresses me how much complexity PCPs are already managing within primary care. So 75% of consults involve 2 or more diagnoses, and a third involve 3 or more diagnoses. Next slide.
I think in 2 ways primarily. I use CalMap a lot. Is one, through the pathways. I think for a lot of my teen patients specifically, looking at prescribing guidelines for ADHD, for anxiety, for depression, and then also eating disorder criteria, I think has been really, really, really helpful. And then the second way is like the on-call psychiatrists and the case managers for especially my kiddos with autism or other like developmental disorders or diagnoses that really need a lot more support in terms of case management and school and like linking us to all these different resources, as well as medication management in real time, which I think is really helpful in clinic. I think it's one of those systems where you're like see one, do one, teach one. And so because I have the support of psychiatrists and other mental health professionals, if I have a question on something, I think the first patient that I see in that situation, I'm able to consult them. And then the next patient, I'm able to kind of be like, oh, I've seen this before. And so I think that's definitely like increased my knowledge and skills around the areas that I consult CalMap on.
So what she's illustrating there is really this ripple effect of consultation. And so this isn't just about helping the one patient, that you're consulting about, but more so how our PCPs kind of expanding their knowledge, skills, and confidence in addressing a lot of these conditions. And this quote really captures it, that Dr. McCracken was very helpful, thorough, and provided me with information that will help me not only now with this patient, but in my future practice with my autistic patients. Thank you. And that's really the idea behind this. Next slide. As somebody who initially chose to go into pediatrics and not psychiatry, because I was in med school in the late 90s when everything was about the receptors and just biology, I'm really proud to say that the number one thing that that PCPs endorse is improved ability to speak with parents and caregivers about behavioral health challenges. And then we also have some really compelling stories around practice level changes that folks have implemented. And then, lower down here is use of psychotropic medications, which is absolutely something that we teach, but it is, meant to be kind of a holistic, whole child, whole family, perspective. Next slide. I think these next few slides, the last ones, we're going to just maybe breeze through a little bit because we want to make sure that we've got time for questions. But really coming back to, this is about getting the right care at the right time, in the right place, and for the right length of time. And we've got a lot of wonderful quotes about this. We also really support behavioral health screening and interpretation. We know from ACEs Aware that that a lot of people feel like, well, okay, I don't know what to do with a score, or even if I do know what to do with a score, I don't know where to send folks. And we are seeing a lot of increased use of behavioral health screening tools, not just the PHQ-9s, but other appropriate ones. And this publication from Michigan is demonstrating that, kids who had a CPAP consultation had much higher odds of accessing the right types of care, including therapy, follow-up, and appropriate prescription of SSRIs. Next slide. This is an equity issue because, in really rural and underserved areas where PCPs are overwhelmed with just sheer patient care volumes, that, they may not have the capacity to be able to keep up on the latest and greatest in terms of, mental health assessments and interventions. So this increases access to evidence-based care in a culturally responsive way. Next slide. Another aspect that we're tracking is impact on burnout. PCPs endorsing feeling more connected, feeling supported, and not needing to default to just sending everyone to the emergency room because it's the most conservative and easy thing. And this last slide, if we go to the next one, just demonstrates how CalMAP supports and aligns with the goals for not only the CYBHI, but also CalAIM and behavioral health transformation. And really importantly, what's consistent across all of these is this timely access to quality care, and also improving the quality of the care experience and overall quality in terms of value-based initiatives. And I think we'll pause there for questions.
I love the sunflower slide. Thanks to you both so much for the information on this super important and impressive program. I do think that it's not surprising that people are screening more when they have the tools to know what to do once they get the screening results, and that I think there has been a lot of fear about asking the questions. So maybe I'll start with a question, Emily, for you, and then Petra, you can follow up if you want to. But as a pediatrician, of course, in the world of seeing moms after the delivery and just getting a sense in the room that there's depression and anxiety, I was, as in my practice, it was my instinct that the anxiety was actually higher than the depression. So I'm so glad that that's been renamed and that you called that out. And I wonder how you think about the utility of or recommendations for screening in pediatric practices for maternal care and the increased availability potentially of dyadic services, of being able to treat moms and kids at the same time.
That is an outstanding question. It is a live question because, it's a very strange thing to go through a pregnancy and see your OB once a month, then once every 2 weeks, then once a week. Then they usher you through in my experience, most transformative moment of my life, which is having my children. And then you go back one time and they're like, see ya. And you're just no, but you're my new best friend. It's very hard to walk away from that. But then you hand things over to the pediatrician, right? And the pediatrician is ideally suited to basically do the screening, right? Because they're seeing you at these regular intervals, these prescribed intervals, but you're not the pediatrician's patient, right? They don't have access sometimes to your EMR. You maybe go to an entirely different clinic. Like, it's hard to know what to do. And so we've struggled with this kind of in the reproductive psychiatry community when we make policy changes, because we want to engage pediatricians and we also want to be respectful of scope of practice, right? So it's hard to kind of know how to navigate that. I do think programs like Promise are actually incredibly important because 2 reasons. One, I couldn't agree more that you shouldn't screen unless you have a plan for what to do with the positive screen, right? Like, what I always say is like, oh, okay, let's do this glucose test and you've got diabetes. Okay, well, good luck with that. And here's a piece of paper with clinics and you can call and see if you can get an appointment. Like, we would never do that, right? But with a program like Promise, a pediatrician can call. We do get calls. Sometimes we get calls actually about medication and breastfeeding. So that's the question, something we get. But we also tend to get a lot of calls about resources and referrals, and also about like kind of assessment and diagnosis. Like, this is going on. How worried should I be? Right? Like you mentioned, anxiety. She seems really anxious. Some anxiety is 1,000% normal when you have a new baby, and she's not sleeping and she's not really eating. And should I do something about this? Right? And we can kind of help talk through what to do about that. Dyadic care is, I just think, a godsend. I think it makes a huge difference to have that. I mean, why we separate it to begin with doesn't make sense to me. To have like that mother and infant together is huge. Obviously, if it's in a situation where the mother can get treatment at the same time, it's even better, right? So I'm a huge supporter, and we are in our kind of women's health division that launches Promise, a huge supporter of dyadic care. There are always situations where dyadic care is not going to be adequate, where the mother needs more specialized mental health care, but we can help give resources and referrals for that. So I hope that answers your question. There's a huge, huge need for, the role of the pediatrician. Another thing that, just to throw this out there, and then I'll be quiet because obviously I can talk a lot about it, but, we did just expand Medi-Cal, or not just, but maybe 3 years ago, to cover the full first year postpartum for women rather than just the first 60 days. So there are reimbursement mechanisms now for things like screening and consultation that can further kind of support and incentivize pediatricians to take this on.
Great. Great. And I'm glad you teed up my next question, which is really about reimbursement. I know that sitting in a pediatrician's office where you have a very short visit and lots to go over, that a lot of the fear has just been, how can I take the time to do more robust mental health support across the board, whether it's a mom's been and for the kids we take care of as well. So Petra, you did allude to the resources around billing mechanisms to try to get support for this. And I imagine there are a lot of folks on this call who would love to understand more deeply both sides of it. So just to say explicitly, are those resources available on the website that you shared with us around how to learn how to do billing for this?
Yes, and I know it's just being revised, so regardless, I will, forward it to send out to all participants. But in short, time-based billing on the day of consultation and/or complexity, that you can increase those. And people often feel anxious. No, I shouldn't do that. But you just spent, 10, 15 minutes talking to somebody. Of course, that's a coordination of care event. And then for outside of the same day, you can bill a telehealth code that helps for, or is used for e-consults as well as phone consults. And that's a 99245. And so we can share that out.
Great. Great. Well, we did get, I have so many great questions from this audience as always, but one question I just want to mention as we wrap up is one of our participants asked, how can we advocate for more free and low cost social support? So I love that spectrum you had, Petra, but this is talking even about sports teams, community events, third sources to support resilience and prevent mental health issues. And so as we are part of CMA putting this together, just mentioning for all of us physicians and other healthcare providers on this call and in the community, how many ways that we can support as a village all of these mental health things. So I think there are opportunities for advocacy in many, many ways around this. I am so grateful. I wish we had half an hour more with each of you, but just as a reminder, you can get CME for this. Our next session is in, our next session is in 2 months, and it's going to be around some of the issues, challenges around federal funding, around public health issues, around vaccines, other advisory issues, advisory boards around perinatal screen, or not perinatal screening, newborn screening have gone away. So how do we make physician decisions as clinicians in the setting of changing evidence based advisory committees? So I'd recommend that all of you come to that. And then you do have access to these slides. And so I know that many of us want more robust educational resources, and you can get that through the links that Dr. Steinbushel shared and Dr. Dossett, and very grateful for you both here today.
Thanks so much.
Thank you so much. Thank you.